State Secretary IAP TNSC Dr. Rajendran sir to the CME, and our State President Dr. Ramesh Babu has expressed his best wishes, and as he could not join, he asked Dr. Rajendran to do the honors. I invite Dr. Tirumurugan, our next State Secretary, Dr. Chendil Aram sir from Neyveli, Dr. Usha ma'am, our President AHA Coimbatore chapter, Dr. Vijayarani ma'am, Dr. Sri Priya from Vellore, Dr. Jayashree from Coimbatore, and Dr. Ismail sir will join in a few minutes. So I invite Dr. Rajendran sir to inaugurate the CME and express a few words.
Yeah, good morning to everybody, and respected our President Dr. Ramesh Babu and incoming Secretary Dr. Tirumurugan sir, and my mentor and guru for IAP Dr. Aran Chendil sir, and Coimbatore AHA President Dr. Usha, and Secretary Dr. Lashmi Santi, and all faculties from all over Tamil Nadu. On behalf of IAP TNSC, I welcome one and all for this wonderful event. I think AHA chapter, they're doing very well, extremely very well, and after taking over this group. And I think my best wishes for this future endeavor also. And I vividly remember that last year, I think AHA that got a national award also for this Noida Pedican. I think this year also they continue same. And my best wishes for the.
Thank you, sir. Thank you for taking time and efforts to join from Bhuvaneshwar, sir. So you have always been very supportive and encouraging of all the activities. Thank you so much, Rajendran, sir. So shall we move on to the academic session? The first session will be the parenting challenges that we face today with today's adolescents. So this session will be moderated by Dr. Vijayarani ma'am from Vellore and Dr. Sri Priya from Vellore, who are both of them have been very active AHA members and doing a lot of services. Dr. Vijayarani ma'am has a separate center to deal with adolescents presenting with problems and behavioral challenge. And Dr. Sri Priya is attached to the ESI Medical College and Hospital, Vellore. So I invite Dr. Vijayarani ma'am and Dr. Sri Priya to take forward this session on parenting challenges, cues, and solutions.
Thank you, Dr. Lakshmi. I first thank the Indian Academy of Pediatrics Tamil Nadu chapter and the AHA Tamil Nadu chapter and all the office bearers for giving us this opportunity on a very important topic. And we shall move to the CME. Shall I do this share screen?
Yes, ma'am.
Yeah. How do I share? It's on the
share screen, ma'am. It is enabled.
Yeah.
Otherwise, Sri Priya, can you do it?
Share.
Yes, ma'am. The screen is visible.
Yeah.
Put it in slideshow, ma'am.
1 second. Yeah. Your children are not your children. They are sons and daughters of life's longing for itself. They come through you, but not from
Ma'am,
you.
can you just
And
go
though
to...
they are...
Ma'am, slideshow la potru. Okay, okay. Yes, carry on, ma'am. It's visible. Carry on, ma'am. It's visible.
Yeah, yeah. This is a poem by Khalil. Was impressed upon this fact, this natural process. The children are coming through us, but they don't totally belong to us. So we have to keep that in mind, especially during adolescence, when we have to let go of our adolescence. So with changing times, we have a lot of challenges to deal with our adolescents. And it is very important for the parent to understand that it is an opportunity given to them, and this time shall pass very soon. Unlike in olden days where families were very big, a number of children were by your side. There is no perfect parenting. It is only the common sense that prevails. Parenting as such, the word parent only came in the 15th century, derived from a Latin word. And there was no sessions or no coaching for anybody. It's a biological, natural process. No other being were taught about parenting. We just evolved. Also, every season, the parenting is not one set thing which we have to really learn and do it. It evolves as time changes. And because we are seeing a lot of issues, we are guided by the studies and evidence-informed recommendations. Some of the studies are very, very difficult, like in other scientific studies. And though overall we have parenting styles like authoritative, authoritarian, neglecting, permissive, kangaroo parenting, helicopter parenting, whatnot. Nothing is exclusive. There is merging. Not people don't use one specific type of parenting throughout. It is not so. And it is a natural process. And the adolescents are going through their process of identity and trying to become independent. Along with the parents, they are going through their mental process of letting go of their child safely. That concern is there. If we see the other natural beings like birds and animals, it is not so. And we are higher, better evolved. Our brains have evolved so much that we are unable to let go of the children. We are always concerned about their safety. There are the old challenges and new challenges. Old challenges like we've seen coming late, they are fussy about their food habits, and they want to do some risky behaviors, all these things which over many generations we have faced. But the new challenges are with the changing environment. We have the digital era, the nuclear families, and the societal pressures. Let's see all those things in the coming sessions. Pediatricians not only have a role in controlling infections and regarding growth and development, now we are given the greatest responsibility to nurture positive mental health, reduce the risky behaviors, early detection of mental health issues, and healthy sexual and reproductive behavior. And parents come to us for guidance, and it is our duty first to be knowledgeable ourselves and then give them guidance. Again, there is no perfect parenting. We just give them guidance. Just like the DNA and the chromosomes, there is the combinations of the nucleotides are varied and in millions. Same is the characteristics of the parents as well as the children. So there is no fixed characters like for this you do this. So we have multiple factors, multiple case presentations, or multiple issues to be dealt with. And we have to use our maturity, our scientific facts, and our own experience to guide these parents. What are the common challenges and the newer challenges? Eating behavior, fussy eating behavior, either they eat too less or too overeating or unhealthy food, junk food, all these things. Along with the clothing, we have become very, very global. And the hairstyles which peculiar to the adolescent, they want to keep up with the trend. And the makeup issues where you don't expect or overly. Teens' choice of friends. We put our thoughts. We think this is good, this is bad, and we want our teens also to choose those kind of friends. School and work performance, it becomes the prime thing, especially in our country, more so in Tamil Nadu. Academic performance has become the first problem. Usually parents come with this dispute over teen curfew, coming late, sometimes birthday parties, they come, they stay, sleep over. All these things are happening, always a tussle with the parents. This has been happening for quite some time. And the time the teens spend time with the family, their choice of spending more time with the peers, there's also a tussle about it. What are the new challenges that we have to face? Time privileges, yes. Though the licensing age is 18 years, children, adolescents want to do it much earlier and they ask, and then there is always a fight, or sometimes parents are permissive. The indulgence with cell phone is a newer thing going on for the past probably 8 to 10 years and more so, and it has increased multifold with the advent of smartphones and post-COVID. Dating and sexuality, again, this has become very, very global. The issues are the same. Only the culture varies, but the issues are the same everywhere. High-risk behavior with so much of environmental changes and safety issues, it is of great concern to everybody. Self-destructive behavior by getting into smoking, alcohol, and drugs. So we need to, itself, parents don't know how to take care of these issues. They come to us for guidance. So what are the solutions to these problems? It could be an overall guidance, like first they must know the development of the brain, which is not uniform in the adolescents. That is causing the main issue. The prefrontal cortex are yet to mature, whereas the limbic system for the emotions are already matured. There is a difference in the maturation of the whole brain system. Myelination is taking time. So this conflict of the maturation rises to the high emotional exuberance of the adolescents, and the inhibitory nerves are yet to develop, so they are unable to control their impulses. This fact needs to be told to our parents, that they have to maintain patience and analyze the behavior of their own adolescents and have an insight on how to take care of their adolescents. We must, it is the duty, as long as we take the role of a parent, there must be a safe and loving home environment. That will be the core, and where the children we can overcome the parenting issues if the home environment is loving. Unconditional love. There is no barter system for this. You do this, you get love. Only I will love you if you score high marks, if you do this, if you go to your classes regularly, if you do the tennis. No. Unconditional love is beyond all this. After all, they are our children. And the expression of this and understanding of this by our adolescents build strong bonds, even if they are pulled into the identity crisis of theirs. Work-life balance, the most crucial is the time we give as parents to the adolescents. Very, very important. Whatever, though we talk about quality time and how much we are giving, it must be really, really more during the time of adolescence. We'll be seeing about that. Effective communication is the key for solving conflicts. So we all see parents having cell phone and then talking to their adolescent. They will be talking something and then they will be listening both to the adolescent as well as over the phone. And children will be talking, their thoughts will be somewhere else. Moms are very busy in the kitchen and they come and talk, they are listening, they are very resentful. Adolescents are resentful. And then they don't, next time when they really want something to be told, they don't choose the parent to share, they choose somebody else. And the big no to criticism. This is what most parents do. Always criticize them. You're not doing this. You're not good at this. You're not putting enough time in your studies. That is why you fail. Or that is why you score less. Even for a topper, there is some criticism. You've not got the first mark. You've not achieved this. Even in sports field, you have to do this. You have to do this technique. That is why you've lost your goal or whatever. So criticism really pulls away the adolescents away from us. Societal parenting should not overrule your inner parenting voice. Very, very cruel, the society's attitude towards our children. What it happens. My son is doing this, my son is doing that. Oh, is it? He is number one in this. So ultimately it puts pressure on the other parent and trying to ape. So there is no competition in parenting. We must all understand that there is no rat race. We have to align our expectations versus reality. Every parent must be told this fact that what is the child's passion, what is the capability of the passion, adolescent, and how much to expect, and what is exactly the reality, the other factors. A few words about effective communication. Active listening is very, very important. That is what I said. You cannot keep seeing the TV or seeing the cell phone or doing some game yourself and listening to your thing. Keep aside your cell phone. Have eye contact with your adolescent. Listen. When they come with issues, it is very, very important that you give active listening. There must be non-verbal communication. The way you need not sulk, you did not show. When we must teach these things to the parents, that they must be showing interest in their eyes and their body language and how they sit across their adolescents to listen to these when your adolescent is conversing to you. Exclusive time is very, very important. If you don't have the time, then you tell them, now I am busy. Can we talk at this time? Or what is the right time for you to talk to me? Something like this. Let us not take in our own setup this kind of effective communication. Please understand there can be single parents, there can be a dysfunctional family, there can be a child with disability or specific disabilities. All these things must be taken into consideration. If I'm saying active listening, those people need more time and more eye contact and more love shown via their non-verbal communication. Time is crucial, non-critical. When you give time, though in between, we should not intersect and say, oh, you did this, that is why. And then don't be very critical of all their views in between. You have to understand the adolescent. And we should not have our own bias, especially with dating, having girlfriends or boyfriends, or some other issue. When they tell you, don't be very judgmental and think that the adolescent is going to through some other pathways. That is why he or she has got into some trouble. So your own biases can affect, and your adolescent can become very resentful and will not communicate. So let's see what our friend Dr. Shripriya wants to say further from this, how we can connect emotionally with our adolescent. Thank you.
Thank you, ma'am. Thanks to IAP and my adolescent fraternity. Now let's hear the voices of some teens. My parents turn everything into a lecture when I just want them to listen. I feel emotionally unsafe to talk to them because they just react and blame me. They just don't seem to understand me. It is not safe to talk about my feelings because my parents become sad. Many of us will be able to relate to these statements. And yes, when the teen is having big outbursts of anger or is upset, what do we do as a parent? How to respond and not just react? Next. This is when we can teach them emotional regulation. When both the nervous system of the teen as well the parent are in flight or fight mode, then nothing productive can happen. So first, reset and anchor your own nervous system. The parent should take the blame off from themselves so that they will be in a better space to think. Be mindful. Next. Recognize the teen's feeling and label the feeling. For example, you're really angry now. You seem to be upset. Many a times, just naming the emotion will calm them down. Next. Next, ma'am. Acknowledge their feelings and validate their feelings. Like, for example, always when having a conversation with the child, have it in a heart posture, that too, an emotional conversation. Like you can say, I see you, I understand you, I'm going to do everything I can to empathize with your side of things. So first, connect before you correct them. Next. Next, ma'am. Identify how they feel the emotions in their body. The previous one, ma'am. Previous one. And many a times, the emotions, the bodily sensations will help them to reach out for anchoring or help even before it escalates. Next. Next, ma'am. Take a pause. Previous one, ma'am. Previous one. Take a pause, like saying, I really can't hear you when you are in the space. I want to understand. So let's both take a moment. This is not slamming the door on the face and going, but just taking time to ground yourselves. And finally, when he is in a receptive state, when he is able to hear you, then both can sit and reflect what can happen. Like saying, how do you think you could react when it happens the next time? So to guide for teachable moments, remember the 3 C's. The connection should be high, the conflict should be low, and both the parent and the teen must be calm. Next. Suppose the child shuts down. What should the parent do? Go and engage with them. Maybe just sit down with them at that moment, just being present with no expectations. And later, if you see some energy, you can start talking. Remember, all behaviors are communication of emotions. Next. Next, ma'am. Next slide, please. Do not have any sense of, previous one, ma'am. Do not have any sense of urgency. Previous one, ma'am. Many times, the parent think, I have tried this. I have empathized with them. The next one, ma'am. I have empathized with them for 2 minutes. Now it's time. Let me try my own ways. No. Slow down all your expectations and then patience, persistently following it is the key to success. So the more a pathway is used, the more established it becomes and more it will become the chosen route. Next, ma'am. We have to remember unexpressed emotions will live their own life in the subconscious, bringing forth more damage than probably intended by the one who is suppressing. Thank you. Over to Madam.
Thank you, Doctor. So this emotional very, very important for the parents as well as a life skill to be given to our so that when they go into their adulthood, they will not be facing the handling of their life issues in a very messy manner. It's very, very important how they handle their partners or their professional colleagues or in the workplace or the fellow human being. They have a lot of challenges, and we ourselves as parents will have challenges, both new and old. So what are the new challenges? We are become nuclear families, but there is the other thing to it. We are not dealing with the big family. We may not have the support of a big family, but we are a small family. After all, we have 1 or 2 kids. But again, understand nuclear family is a normal what we are talking. There can be a single parent solo attending to the adolescent or adolescents. They may be having sibling and unattended to. If there is a parent, then the mom and dad must have a common philosophy, what is going to guide them. What they cannot have, each one cannot their own type of parenting handling adolescent. It will confuse and the adolescent may take it as an advantage or at the same time may be confused, not fitting into any of these patterns. Again, we have lives, both are earning parents or going for work or something. At the same time, we have great expectations. We want them to be academically excellent, doing all their extracurricular activities, hobbies, At the same time, fit into our own days of adolescence, which is an impossibility. And we are ourselves overburdened and overwhelmed by these factors of handling the day-to-day affairs. And also, adolescents are overburdened with their academic pressures and their wants during their adolescent development. So there is always a feeling that I'm not good and may contribute to lower self-esteem. The next is the bigger issue now, the digital era parenting. I've already said both the parents are involved in the cell phones or TV or the games. And how are we going to deal with our adolescents? The whole world revolves around their phones. Emotional connections are becoming less and less. We are forgetting our hugs, our expression of love and affection, and the time we are giving for our adolescents for bonding. Again, parenting better than yes. Who is doing best parenting? I'm taking my child, I'm putting the daily taking the child to the school, after school, taking for extracurricular activities, then spending my time for the homeworks, etc. I'm the best parent. No, there are so many other things. Please understand each one's living is different. There is no competition between parents. This fact, again, all these things must be impressed upon to the parents for them to handle their own adolescence. Okay, what are the common issues now they're coming with? Children are back talking, not listening and stubborn. So very, very difficult to handle. More because of permissive parents who had been very, very permissive and the children had never heard about no. Now, when they're moving into adolescence, suddenly the parent wants them to listen and frame rules which they wouldn't. They question us. They question the parent. Why you are doing that? Why do you ask me not to do it? And all along, they had been really analyzing and asking questions openly. You cannot expect them to keep quiet. Again, parent are themselves, see the picture, the parent are themselves. This is a very common sight. When you travel, you can watch. When you are in a restaurant, please watch around. You can see all our professional colleagues are already aware this kind of features, parents involved in thing, or when a group of friends, everybody having their cell phone in their hands. Digital era parenting, less of emotional connection. What Dr. Shripriya has said is very, very important that we teach, which was a natural process. Now is the time to teach our parents and our adolescents for the emotional IQ, EQ. There can be other factors too when the children are listening, not listening to you, or back talking, or very stubborn adolescent. It is really very, very difficult. It's a very difficult parenting situation. We also have to think about oppositional defiant disorder, ADHD, poor impulse control, conduct disorder, or there is a dysfunctional family which they have to deal. And also, we must have to keep in mind the other factors like sexual abuse and the influence of media. This can be different from the defiance of an adolescence, which is very, very temporary because the adolescent is going through the process of self-identity and the fight for independence. So at that time, they may be very defined with the parent, but they will settle very soon. Only if it is very chronic, more than 6 to 1 year, then you have to think and then do the assessments. We can see, adolescent parenting, it is very, very good if they start early. We cater to parents. Now we even cater to young adults pre-conception time. Okay, our own children, adolescent, then they get married and they come back to us. So so when they become young parents, it is really very right for us to start talking about parenting issues. And if the parents are going to be like this very young, they really want our time to be spent with them. And now when you move into your adolescence, then it is impossible to get their attention. They will never come back to the parents. So it can be very difficult the behavior of the parent during the early childhood. So very, very important that we are aware. The parents are aware about involvement of a digital media in their lives. So the kind of cases we see may not always come with complaints of digital addiction. A mother brings her daughter for sleeplessness, not eating well, irritability, falling grades. We have to do the head screening, get into the details of what is the home environment, what is the diet, what other factors are there, and then definitely about usage of screen time, how much the adolescent is involved in screen time. Very, very important. I found that in this particular case, the daughter was using cell phone, especially during COVID and after COVID, their indulgence is quite high. So we have to give a set of rules, what to be followed, and that cannot be done. Just give the rules to the adolescent and follow. The whole family has to take care of this issue. Everybody has to follow these rules in the family, and they have to keep track for the adolescent to come out of these overindulgence and come out and prevent addiction. There was another farmer father who brought his son with the only complaint, refusal to go to school. So at the first, when you take the heads, then you think about scholastic backwardness. We kept on asking whether he had any issues of learning disability, asked him to bring books, everything. But soon, before leaving, the father showed a smartphone and he said, oh, all the time he's engaged in this and thing. And then he wouldn't separate himself from this thing, always sleeping with that. So now, further questioning the adolescent, he's become really addicted and it has become a bigger problem. He even tried to take away the phone, then the adolescent became aggressive, or he runs away from home. He threatens the father that he wouldn't come back home. Similarly, another parent brought a son already aggressive, and they know the son is indulging in if the phone is naturally, he throws things and really sometimes can become very violent. A mother brings a daughter of low moods and sadness, lacks interest in a daily activity. So it is not just the indulgence. What are the contents they are seeing? What is it happening to them? Are they being bullied by somebody? Are they feeling low self-esteem because somebody else is posting pictures of beautiful locations they are going, beautiful dresses they are wearing, much more beautiful than others. So many adolescent likes them. So we have to probe, and then we have to build the self-esteem, guide the parent, how all these things can be done. There's another parent who brings the daughter for a love affair with an adult. So this is also an issue, engagement with the smartphones. Then slowly they get connected with somebody. We have to talk to them of various issues regarding, we should not partner with the parent to discourage this love affair. Rather, give them the real facts about the laws, about what is happening in their thing, the hormonal effects, the infatuation matters, and empowering the adolescent. What are her future goals and her how she can stand on her own to become empowered and be independent. So the challenges can be many. We'll be seeing further on these lines. As well as once it is addiction, it is little confusing, or people don't want to use the word addiction because addiction means it's really a strong word. So it can be overindulgence, and DSM-5 has stated this as internet gaming disorder, often co-occurring with other issues like depression, ADHD, ODD, etc. But we must also let our parents be aware that it is a disorder, and immediate attention must be given to it. And there are treatment processes which they have to spend time. The parent has to spend time bringing the adolescents for treatment. and also give them set rules how it can be done. It cannot be done on a sudden change in attitude at home and rules at home. It has to be in a pattern, and also there must be extreme patience on the side of the parent, and they have to partner with the school and friends how to this addiction. And now it is already to do a digital detox for parents, for everybody, and specifically for adults. When they go for these long trails into nature where there will not be signal. So some of the studies have indicated children during the holidays, when they go for these nature trails, when they come back, they can self-analyze themselves that they had been kind of addicted to this their screen time, and it has to overcome this indulgence. Parenting challenges with every phase. It is happening with every phase. Toddlers are different, adolescents are different. And it is a constant process. When just because they become adults doesn't mean they stop asking us for guidance. Also, my professor, Professor Grayton, said, we build ships not to stay in the dock or the harbor. We have to let it sail into the ocean or sea. They will have to face, the ship will have to face a calm ocean or a turbulent storm. So we can no longer protect our children every single day. Adolescents have to become independent from us. They have to move into the seas to see the challenges. They have to experience. They will come out well if you build the ship strongly with those life skills. Letting go of the children is a natural process. We cannot hold on to them. It is very, very detrimental to the adolescent as he or she becomes that adult. Parenting, everybody learns. Every day is a learning process. Recently, when we met during the NCPID, all our colleagues were talking. Then when I said my recently what happened in my one of my festival day, my adult son came, and after we switch off and relax, my adult son came and sat or lied down between us, between the father and the mother. Then all our colleagues said, oh, nice to hear this, Vijayarani. I'm very glad this is normal, that it's happening to you, it's happening to us also. So this is a normal thing. Parenting doesn't stop abruptly once the adolescent become adult. They come back and seek our thing. The same, the parents, when they come, they should be guided, and we give them according to the changing times, we have to give them the skill. Unconditional love is the key to this. So further, we will see Dr. Sri Priya, how she's going to deal with these things. Thank you.
Another important challenge for the adolescent is body image issues. So to understand about these issues, let us see these two scenarios. 15-year-old Dhruv feels that his jawline is not as chiseled as Hrithik. Why I am not taller? My shoulders are not as broad as I want them. I wish I was more muscular. Next. Next, ma'am.
No, it's not moving. It's not moving. Yes. Can you see?
Yes, ma'am. 14-year-old Kesha says, I hate to see myself in the mirror. Pimples on my face make me look ugly. And oh, my hair, it should have been straight. I wish I had bigger breasts and a slimmer waist. I envy my friend Shreya, who has a perfect figure. Next, ma'am. So what is body image? Next, ma'am. Next, ma'am.
Yeah.
Body image is what you perceive, think, and feel about your body. And it does not necessarily reflect what you see in the mirror or what other people see. Next, ma'am. It is influenced by various factors such as media, peers, friends, relatives, and parents. To develop a positive body image, let us see how parents can help. How you talk about your body or others' body or your child's body strongly influences how the child views their own bodies. So, no derogatory body conversations. Many a times, parents are worried that their child must not be bullied by others, and in the process, they themselves become a bully. They think body shaming is a potent way to motivate the child to transform their own bodies, but only they make them feel insecure. Accept them as they are, love unconditionally, as Madam previously said, and unconditional love from the parent will be the foundation to face unacceptance from the people in the world. Focus them on being healthy. During all your conversations, focus them on being healthy. Focus them on being beautiful as they are. Focus on what their body does to them rather than what it looks like. This we call it as body neutrality. Rather than changing them to become confident, help them to feel good about who they are now. So this type of inner validation will build their self-confidence and keep them more included in social activities, sports, etc. This is not to become an amazing professional athlete, but this helps them to build connections. And when they see what other bigger bodies can do, their perspective will change. Next, ma'am.
Thank you, Doctor. So we've just given a kind of overview about happy parenting and hello.
I think I have another slide, ma'am. Shall I just proceed with that? If the slide is not visible, it's okay, madam.
No.
Okay. When a child talks, next one, ma'am.
No, this is the last.
It's okay, madam. When a child talks negatively about their own body, ask the child why they feel this way about their body and be sure to listen closely to them so that they feel heard and understood. Encourage them to identify their best non-physical qualities. This can be displayed as small handouts in their rooms so that this will give them a reminder how great they are. All body positive affirmations also can be kept as statements near the mirror. Help them, teach them to just cut the negative self-talk and treat their body in the same way, with the same kindness as they will treat their friend. And no verbal abuse, especially to yourselves. Encourage them to be around positive and supportive people who see them naturally as they are. Thank you, ma'am. Thank you all.
Thank you very much, Doctor. And see, this is what we are aiming at, happy adolescence. And that must be though happiness can be very elusive. So the role of pediatrician is to guide and give them skills to maneuver their adolescence. And we can spend a few minutes for parenting also. Thank you very much.
Thank you to the dynamic duo from Vellore, Dr. Vijayarani ma'am and Dr. Sri Priya. Both of them have been very instrumental in promoting adolescent health, especially from our Tamil Nadu state. So thank you for giving an overview. So as Vijayarani ma'am said, digital era parenting has made parenting very difficult in today's day. And as Dr. Sri Priya said, doing this emotional coaching, not only in adolescence, even starting a bit early from when the child is very small, connecting with the child, doing this emotional coaching and able to name the emotions and finding solutions can be started even before adolescence so that they may become more resilient when they become an adolescent. So thank you, ma'am. Thank you, Shri Priya, for that excellent presentation. So moving on to the next session, we have some interesting case scenarios based on behavioral challenges that we face in adolescent age. To do this, I invite upon Dr. Jayashree Ashwath. She has been a very active academician and a pediatrician from the city of Coimbatore. She runs Ayush Child Care in Coimbatore, and she has been very actively taking part in adolescent related activities in schools and in partnering with NGOs, a good friend of mine. And to moderate this session, I invite upon Dr. Chendil Aram sir, who is a well-known face in IAP TNSE. He has been the president, secretary, and at present, I'm very happy to say that he is the EB member of AHA South Zone for 2023, and is also the Central EB member of IAP TNSE 2022 and 2023. He has been very passionate in promoting adolescent health. He has been our mentor for doing adolescent activities and CMEs. And with his post as EB member of South Zone, we look forward to do more and more activities in 2023. So welcome you, sir. So over to Dr. Jayashree and Dr. Chendil sir to do this session on behavioral challenges and what are the solutions.
Thank you, Dr. Lakshmi Shanti. Am I audible?
Yes, sir.
Okay. So today is AHA Day in IAP TNSE, and this has been a wonderful session, first session by Dr. Vijayarani and Dr. Sripriya. எல்லோருக்கும் வணக்கம். இன்றைய சூழலிலே நாம் வளரிளம் பருவத்தை எப்படி கையாளப் போகிறோம் என்பதும் பெற்றோர்களை எப்படி கையாளப் போகிறோம் என்பதுதான் இன்றைய சூழல் மட்டுமல்ல, எதிர்கால சூழலாகவும் இருக்க போகிறது. தமிழ்ல ஒரு பழமொழி உண்டு, 5இல் வளையாதது 50இல் வளையுமா அப்படின்ட்டு. இன்றைய காலகட்டத்துல 2இல் வளையாது 20இல் வளையாது என்பதுதான் நிதர்சனமான உண்மை. So as Dr. Lakshmi Shanti was also telling, parenting should be taught early, and the children have to be caught early, even between 2 to 6 years. So 2 to 6 years is the right age for them to be inculcated all the values, so that the neuronal network gets formed and gets its proper connections. So today's topic by Dr. Jayashree, Adolescent Challenges, Cues and Solution. We are going to take, because of these emotional issues, the behavioral issues are cropping up, emotional challenges in children and adolescents. So we are going to deal about two important problems, behavioral issues. One is going to be scholastic backwardness and another is obesity. Scholastic backwardness is the commonest educational problem in adolescence, and this is the main reason why there are school dropouts in India, and mainly they are due to the unsatisfactory academic performance. Of course, it has got a multifactorial etiology with it can be neurodevelopmental, emotional, or environmental or medical factors, which Dr. Jayashree is going to be in detail throughout our talk with two important case scenarios. Of course, the scholastic backwardness has got so many reasons and so many causes, but more of light has been put on the specific learning disorders and autism and all these ADHDs and other things. But the slow learner and the IQ has been, which are less than 90 or 70 to 90, those areas need to be concentrated actually. And so let us focus on the problems on today's adolescents, because they don't know they don't know how to take about the challenges, how to face the challenges, and I mean the trending challenges. The world is evolving so fast. The adolescents are faced with so much of, and of course, when the parents are not able to, withstand or encounter or cope up with the current trends, how can we expect the adolescent to cope up with the trends and existing standards? So we have to be with the current trends. And so Parenting has to be there, and adolescents have to be counseled, and it has to be in collaboration with teachers and or teachers also in the schools. And in 2023, we are going to bring out a program. Central AIP is going to bring out a program involving the schools like Mission Kishore Uday. So in 2013, so let us hope 2023 will also bring about many adolescent problems to be tackled throughout Tamil Nadu, and we'll do a wonderful job. Over to Dr. Jayashree. She's a wonderful adolescent physician from Coimbatore. Over to her.
Thank you so much. Good morning, all of you. Am I audible and is my screen visible?
Yes, Jayashree.
Yes, please proceed. You can go to the slideshow. Slideshow.
Where do I do it? Yeah. Slide sorter is there.
Mela, Jayashree, it's in the top.
In the
File, home, insert, design. Animations pakatala, slideshow.
yeah. Yes.
Yeah.
Thank you.
Yes, you can
Morning,
carry on.
all of you. Thank you, Dr. Sendil, for that nice introduction of this topic on behavioral issues in adolescence. Both Dr. Vijayarani and Dr. Sripriya have set the CME started very well, and they have set the platform for the same. Having listened to parenting for the past 30 minutes, now we move on to the next most important issue which we see as we deal with adolescents, which is the emotional as well as the psychosocial issues which lead to behavioral disorder. So through two case scenarios, we have tried to cover one or two scenarios which we commonly see as a practicing pediatrician. As PG, that we were taught as pediatricians to diagnose a condition, treat a child, and also tell the parents what medicines to be given and so on. But even till now, even in post-graduation, we are not taught much about how to motivate children, how to be an effective counselor, and how we should sufficiently equip ourselves with knowledge as well as skills to do the same, especially when we deal with adolescents. I think this is high time that these skills are also taught in into pediatricians during their postgraduate days, so that we will be able to do this effectively. As we all know, in this age group especially, they don't come much for physical problems. And 80 to 90% of the time, we are going to see adolescents with more of mental issues or psychosocial issues, for which our understanding, our approach, as well as our skills have to be completely different. With this background, let us move to the first case. So this is a 15-year-old boy who was brought to our adolescent clinic in the month of November by his parents. His presenting complaints were feeling anxious many a times in a day, and associated with increased heartbeat, palpitations, inability to concentrate on studies. He was not able to focus now and then. He was finding it difficult to keep his mind on books and listen to classes, and falling grades over the past 3 months. He had sleep disturbances. He used to wake up during nights and then find it difficult to go back to sleep. And his sleep cycle also has been postponed to midnight or beyond midnight. He had poor appetite. Now and then he complained of upper abdominal pain, vague feeling in the upper abdomen and bloatedness, and some amount of weight loss was noted. There was no past history of such feelings. Academically, he was very sound. And in 10th grade, now he has moved to 11th grade, and 10th grade, he had got good marks, about 85%. There was no history of headache, no history of vomiting, no history of any neurological issues clinically from the history, and also no history of altered bowel habits. There was no past history of seizures or any history suggestive of therapy given for autism or ADHD when he was a child. He had normal physical growth with appropriate weight and height. And we all know when we deal with adolescents, our case sheet is going to be slightly different, because in a child, we will end with a physical history, and we will deal a little bit about history suggestive of mental health. But when it comes to adolescence, we deal a lot more in a detailed form with what is called as HEDS assessment. Lakshmi, there is somebody talking in the background. Is it possible to mute?
Chendil sir, I think, sir, unmute, mute பண்ணிக்கிறீங்களாங்க sir? Chendil sir.
Sir is muted. Sir is muted.
Okay, அதுல தான் எனக்கு சொன்னேன்.
Okay.
Fine.
Coming to HEDS assessment, we know HED stands for home, E for environment, A for activities, D for drugs, S for sexuality, and S for suicidal tendencies. So this boy comes from a nuclear family with a younger sister. He has very good relationship with parents and siblings. Both parents are in Agri University and PhD holders, a well-educated, well-knit family. This boy moved recently to a boarding school on his own wish. We need to note that he was not compelled by the parents to join NEET coaching, but however, he wanted to be a doctor. So he moved to 11th grade in a different town, to a boarding school, which is the first boarding experience for him. He stays with his friends in a dorm setup. He has 4 or 5 roommates, and he has not yet developed good peers. He is finding it struggling literally to adjust to the environment. The food is different. He also complains a lot about the food which is oily and not tasty, so hence he was not able to eat much. And physical activity is markedly reduced because more time he has to spend with books, even though he's sitting it with books and he is not able to focus. He hardly plays. Previously he used to be living in the agri campus. He had lot of open space. He used to play well, but now he hardly plays. He is not on any medications and not exposed to drugs so far from the history. He has, however, started masturbating very recently. He feels very ashamed and guilty to talk about it, and doesn't express or discuss this with either of his parents. Feels less confident, unable to focus, and started procrastinating his study. His reading habits became very poor. Feels safe in the place, however, but misses his family. He is able to connect to his family over phone on a daily basis, and the parents are extremely supportive. As we heard about parenting styles, these parents were very positive, and they kept motivating the child over phone and frequently communicating with both teacher as well as him. Now moving on to examination. On the first visit, with little bit of initial introduction and the usual dealing with adolescent, we always maintain a friendly approach. And this child was known to me even as a small child. So he was able to connect to me very well in the first visit itself. However, he was anxious and he had a worried look, very communicative, and the keenness in him to get rid of the present problem was definitely seen by his body language. Not anemic, no goiter. Sexual maturity rating was 4/5, and the growth chart plotting revealed that he was well within normal limits with regard to his BMI and weight and height. Vitals were normal. Systemic examination from head to foot were also within normal limits. There was no suggestion of any neurological deterioration. So now to summarize, we have a teenager with falling grades and behavioral issues towards studies especially, and addressing the present scenario of moving to a new place with regard to education, so which led to recent onset anxiety. So with this background, how to proceed? So now in the first interview, we need to remember that children, especially these teenagers, the problems, what is the root cause, they will take their own time to come out with it. And this is all based on how efficiently we communicate with them and how we are able to be non-judgmental and with a friendly attitude, how we move with them, make them very, very comfortable. And also the important thing is not to disclose whatever they say in the interview to the parents, because that will demotivate them from coming out with the real scenario. So it took 2 more sessions without the parents, of course. With the one session with him alone brought out more clues, and his friends introduced him recently to pornography. And over weekends, weekdays, of course, I think the school did not allow phones, and over the weekends he started watching them and got completely addicted to it, and he was not able to get rid of it from his mind. So he kept on telling that I want to get these feelings out of my mind, but I don't know how to do it, and it is constantly troubling me. I'm unable to read. Even if I open a book, I'm only seeing those kind of pictures. started having sexual feelings, and feels very guilty about masturbation. But he has not revealed any of this to parents as expected from a teenager. So now we come to a problem, the first case scenario, which is scholastic deterioration. So scholastic deterioration in an adolescent is, I would say, very different from the scholastic backwardness what you see in young children, because here the causes are more likely to be psychosocial and behavioral issues rather than physical issue. So in the next 5 minutes to 10 minutes, we will try to define this. What are the most common causes in adolescence and how to make a diagnosis? Because as pediatrician, our role is still to search for an organic cause, because organic and non-organic causes can coexist in the same adolescent, which we should be aware of. Some basic investigations need to be done, even though we have a striking psychosocial issue. And we need to have a good support from our psychologists, friends, and pediatric psychiatrists as and when necessary to assess aptitude, intelligence, and personality. We can call it as IAP. We need to know the intelligent quotient of the child, personality of the child, and also understand his aptitude to counsel him better. So when it comes to definition, there is no one strict definition. By going through various articles, this is what I understand. Like, a child is not able to perform to his intellectual potential in spite of good teaching methodologies and a good attendance. If both attendance is good, good teaching methodology is also adapted, yet the child is not performing to his intellectual potential, we can call it as scholastic deterioration or backwardness. Deterioration meaning it has happened over a period of time, say for a few months. Now, the common causes in an adolescent, like how we have in this present adolescent, is the poor study habits. That means his skills of time management, inability to focus, difficulty in concentrating on the particular work he is doing, or not finishing his homeworks and classwork. So these are the most important reason for scholastic deterioration in an adolescent. Of course, there are physical causes which we have to rule out, like refractory error. A simple recent onset refractory error might be a reason which may contribute, not maybe the only main reason. So we need an ophthal assessment. History of migraine, we have to definitely ask for history of headache in these children, because in adolescence, migraine is a common occurrence. Especially in girls, we need to think about conditions like anemia or nutritional deficiencies and frequent infections. So when a child goes to a dorm setup and be in a crowded place, these children are also more prone for catching viral infections very frequently, because of which they may have issues. Or these children have a past history of hyperreactive airway disease also, where these children can end up with frequent hospital visits, which may affect the performance. Body image concerns, as both Dr. Vijayarani and Dr. Sripriya discussed, very important reason, and puberty issues too. So these keep cropping up as they reach their mid and late adolescence. Coming to the mental causes, we have to assess the IQ of the child, because these children will be able to cope up with minimum portions. But when they are given a huge task of NEET coaching or CLAT coaching or IIT and so on, it matters. Even a few points of low IQ may make them very difficult to cope up with the syllabus. Conditions like ADHD or autism, the developmental disorders, have to be kept in mind, because during COVID, we all know we had 2 to 2.5 years of online education, during which neither the teachers nor the parents had any clue about whether these children had any learning disability. But once they cross this and move to school, then these problems keep cropping up, and we should be aware of it. And it's a good idea, whenever you face a child with any scholastic deterioration or backwardness, it's good to make them give a small reading task in your own setup, and also give a paragraph, discuss and ask them to write, and give a small aptitude test to find out whether their IQ is reasonable, whether they have any disorder pertaining to reading and writing. Psychological issues, of course, are the most common reasons for poor performance at school in this age, which can be anxiety, as we see in this child, stress and depression. Environmental problems play a very important role, which we can call it as CPD, which is peer influence, cyber usage. So usage of media, recent introduction to particular websites like pornography or websites like video gaming, where they start connecting to their friends to get rid of stress only through media. So they start playing video games online. In this particular child too, he started connecting with his old friends from the previous school through gaming because he did not develop any new friends in his own batch. And drugs, we have to keep this always in mind, especially in a hostel setup. Personal reasons. So when we deal with scholastic backwardness, we need to think of three circles around the child. One is the intrapersonal attitude. The second is the interpersonal relationship with the immediate family and peers. And then comes the outer circle, which is the environmental factors. So personal factors where there is maladjustment with the teachers, a maladjustment with the peers, and a poor study skills. The child has lost the focus because he is unable to finish the portion. There is a lot of procrastination. They try to move it to the next day, and somehow the things pile up. And availability of easy pocket money to these children, because we know now the socio-economic status of these parents are also moving higher and higher. And when both parents are working, the child ends up buying small things with the knowledge of the parents and sometimes without. So availability of easy pocket money leads them towards wrong habits. A broken relationship, we know at this age of 15, 16, they also end up with love, romance, and feelings like that, which as pediatricians we need to be aware of. We need to ask questions pertaining to that as well, whether they dealt with any such feelings and had any broken relationships which might have led to scholastic deterioration. Sexual urges, night wetting pants, masturbating are all some of the reasons which boys can have to lead to scholastic deterioration, which also is important as pediatricians for us to be aware of. Now, once we know the cause, we have dealt with through history and also examination, we move to investigations. Any child with scholastic deterioration of recent onset, let us have in mind some basic workup has to be done. However, we know that this child has a very strong psychosocial factor. A common thing would be an ophthal checkup for refractory errors. History suggestive of migraine is there, then we can do a basic workup for the same. Findings with regard to nutritional deficiency like anemia, vitamin D deficiency, which is very rampant now in adolescents. Hardly they go out and play. The lifestyle has changed. Thyroid screening becomes important, especially in a girl child. So history of asking, family history suggestive of the same, or recent increase in weight, or history suggestive of altered bowel habits like constipation, are becoming slow and dull than before. These histories are there, then we need to do thyroid screening. The red alert sign here would be a child with scholastic deterioration also gaining weight unusual or has delay in puberty. If a child gives a history that he has not attained puberty in a girl child by 14 or in a boy by 15, we have to be alerted because there can be underlying conditions which lead to scholastic deterioration. Nutritional deficiencies have to be checked. IQ assessment is a good idea to start with before we counsel these children, and delayed puberty, we will investigate accordingly. So these are some of the red flag signs which we have to be alerted before we proceed with counseling. When it comes to educational counseling, as I already said that we as pediatricians, including myself, are not very well equipped how to go about this. So when I searched for this presentation, I came across this very interesting close the loop. So closing the loop means not only parents are important with regard to child's education, a pediatrician or adolescent pediatrician and a counselor, as well as the teachers. So all three have to work together to close this loop, where the three major factors like improving the study skills, where we need enormous help from teachers and parents through our counseling sessions, and also frame a protocol or a discipline, how to deal with this on a day-to-day basis, how to avoid postponement or procrastination, and objective tests which have to be done to deal with the child's intelligence, personality, and aptitude, for which we may take the help of our psychologist colleague. and resolving personal problems, so which includes both organic and non-organic problems. So all these three areas have to be kept in mind so that we are able to effectively help this child. When a child faces a scholastic deterioration, which is in the form of an academic challenge. So when this academic challenge keeps increasing, when a child especially is into a coaching class, an intense coaching for either medicine or engineering or whatever, so it leads to needs more efforts, and they have to put up more hard work and long hours of work for studies, and during which their attention span should be good and they should be able to focus well. If that is not happening, on the left hand side, as you see, they get little frustrated, as happened in this child, or they get bored and they go off track. It leads to sleep disturbances. They start sleeping little more during daytime and during classes, which reduces their efficiency and performance. So the vulnerability keeps increasing. And this adolescent gets low marks in 1 or 2 tests, and it degrades their mood, and also it leads to more frustration, and this goes like a cycle, and repulsion towards subjects leads to distress. We all know stress to some extent is good, but so far it is a eustress. It is good for the child to keep increasing and enhancing the performance. So if a child excels well and obtains grades once or twice, he or she feels very satisfied, and he correlates hard work and effective management of time and able to read and follow a reading habit pattern leads to success. Then his confidence is boosted and he prepares much better to attain a superior goal, and this we call as eustress. Now coming to this particular child, here I think all these investigations, the basic things came out normal, and as we expected, here the problem was only a psychosocial issue, which is anxiety due to the new change in school, inability to find good friends, and also introduction to internet pornography, which led to complete loss of his acquired study skills and difficulty in focusing, which led to this behavioral issue. So here, our role as an adolescent pediatrician comes in good communication. As we know, communication is the key for everything, especially to a pediatrician, even starting from antenatal to natal period, where we communicate more to the parents. But as we move on to teenagers, here communication has to be direct to the child. So let us follow the KISS principle, which is keep it short and sweet, or short and simple. So let us not mince words. Let us follow the same language which the child understands. And second, we know adolescents have very poor patience, and they want to have short, good advices from us, and they don't listen to long lectures, even our own children. So let us follow this principle and have it in mind, and keep our words and discussion short and sweet, so that they are able to get the message. Active listening is very, very important when we deal with adolescents. So as already Dr. Shripriya said, we need to make sure that we listen to them, allow them to talk first, and then start discussing the problems one by one. When we have certain questions, let us have it open-ended. Like, instead of asking this child, for example, using internet is bad, why did you start seeing pornography? Now this child is going to be put off if he listens to this, because he knows that we are already judgmental, and we are putting him in a corner where he is already feeling ashamed and guilty. So we are increasing that guilt feeling. Instead of that, if we ask him, like, what do you think about internet usage? Is it affecting your studies in any way? So this will be a better option. This is an example for an open-ended question. Let us use illustrations and notes wherever possible, because we know these children are so used to visual impact, rather than just like how we use slides to communicate effectively. In our own clinic, let us have illustrations and notes to deal with adolescents better. So we have some laminated pictures in our clinics, and we use illustrations where we can draw and show them, or we can show magazines and cuttings from articles and so on. And these stories of inspiration figures, like their own age mates who have achieved a lot in their lives, and they appear in newspapers now and then. It's a good idea to have them right away in your clinic, so that you can bring them up and use them to communicate effectively and motivate these children. setting up mini short-term and long-term goals. So in this particular child, now the immediate concern is to set a mini goal where he is going to focus on his studies and get into track in the first few days to few months. And then comes the short term, where it is for a period of 11th and 12th, say for example, 1 or 2 years, and long-term goals, that is to achieve his career, which is he wants to do medicine. So let us split this goals into mini, short-term and long-term, which will be a good idea to start the counseling. Coming to motivation, we should be aware of the methods of motivation. We have 4: intrinsic and extrinsic, positive or negative motivation. Negative motivation meaning punishing a child when the child doesn't do well. A positive motivation is to give him small gifts now and then to motivate him and to perform better. Intrinsic and positive motivation are always better, because only if the child is driven from within to achieve something, our work becomes easy. Let us set realistic goals. So this goals have to be something which the child can look forward to. If you say a child who is getting marks in the D grade and suddenly say they have to move to B or A, it's going to be difficult. So let us set realistic goals for them, for which we can ask them to maintain a diary and also note what they have done on a daily basis and see their progress, which will help them to get intrinsically motivated. Prevent procrastination is very, very important, because a discipline in reading on a daily basis becomes important. To finish the goal on that day, their work also is important and key to avoid accumulation of lots of reading at a particular time. Adequate follow-up of these children is very essential as pediatricians. If we advise them once, we have communications 1 or 2 sessions and then leave them off and see them after 6 months or 1 year, it is going to be difficult, and those children might not have got out of the problem. So give frequent follow-up days so that they come and meet you in person and discuss, because most of the time by just talking to their doctors and telling and sharing their feelings itself will make them better. So assessing the progress is very, very important. And of course, we need the help of a good counselor and also communicate with a teacher. So here, if we have a closed loop where we are able to talk to the teachers as well, whether directly or through parents, because teachers are everything. We can call them as all in all, Raja, or the teachers. They are educators, they are facilitators, they are the boosters and counselors who are spending more time with the child. So they also need good communication skills and maintain a non-judgmental approach. Have motivation sessions very frequently at schools with the help of pediatricians or psychologists, which will go a long way in continuing this trend of motivation. Basic life skill educations have to be done at schools, because it's very difficult to do it on an individual basis, and preventing procrastination, teachers have a very vital role. So to sum up this case, academic achievement is a challenge for adolescents. It is indeed a challenge for parents, teachers, and pediatricians. Our role is to identify the cause, communicate well, find a solution. If it is a physical problem, treat it. If it is a mental issue, take the help of a psychologist and, if necessary, psychiatrist, and form a team to help this child to motivate and counsel effectively to deal with the present scenario, and work in hand with parents and teachers. Adequately equip the parents also with parenting skills like what we listen. So if all these things happen and also happens on a regular basis, then alone we will be able to help the child to perform to his potential. Thank you so much. With this, I end the and
thank you, Dr. Jashri, for that first case, scholastic backwardness. That was really very detailed discussion on it. And there are certain gray areas in this scholastic backwardness which we have to focus as a society, because there should be the nature of the individual is there, a nurturing of the by the parents and teachers have to be taken care of, and the thinking part and the creativity part of the individual has to be seen in every aspect of the child by the parents and the teachers also, so that in future they can become, even whatever they are conceptualizing, they might have their own passion. So the rote memory part of it and the conceptualizing part of it has to be dealt, and the education system has to be also thought of, and then evolution of the individual has also to be a part of it. So these are the gray areas, and of course, pediatrician's role is very, very vital. Whether you like it or not, I will not see these patients because I'm seeing only newborn. I'm seeing only below 10 years. So this is not going to be in future. These problems are going to be on the rise, and definitely now itself, pediatricians' role as gatekeepers. You have to identify. You have to have a basic counseling, and of course you also have to go to the schools to counsel and educate the teachers for their identification of the children and adolescents and give them a mass counseling. So let us go to the second case. It's about obesity, and Dr. Jayashree, you'll be having, I think, we'll be running short of time. Please finish it off because we have got the other session also.
So this second case scenario is a double trouble. This is a 14-year-old girl. She was brought by her father with history of excessive weight gain and short stature compared to her peers. She had attained menarche at the age 13, but however, she has oligomenorrhea, and the periods come very irregular, once in 40 to 45 days. Sometimes for 2 to 3 months, she doesn't get her periods. And even if it comes, it's hardly, very less, sometimes spotting. She consumes food frequently, and junks of late have increased during the COVID times, being indoors. And she also started indulging in cooking by herself, and she ended up eating more oily stuff. Lost her mother at the age of 9, and she lives with her father, but however, she has adjusted very well. This also led to her own cooking because there was no other lady at home to take care of her. So she happily ended up cooking for both herself and her father, and started seeing YouTube recipes and yielding to her temptations. She has good friends and supportive neighbors. Average academic performance, but she is happy at school. Examination, short stature, her height is 140 centimeters and weight was 72 kilos. Her weight has been recorded by me in the year of 2018, which was 49 kilos. So you can see how much she has increased over the past few years. And her mid-parental height, this is only an approximation because from what the father said about the mother's height, we have calculated this since the mother was no more. The body mass index was very high. It is a morbid obesity, and appearance, she had acanthosis. However, there was no goiter or dysmorphism. She was anemic. SMR was 3/5 and her BP was normal. Systemic examination, there was nothing abnormal about cardiovascular system, and abdomen was fatty with hepatomegaly. Her waist circumference was more than expected. We know this dictum from our pediatric endocrinology colleagues. Any girl child with short stature, karyotype is necessary. So in this child also, however, it was late. She was already 13, but still we did it, and she turned out to have mosaic Turners. So, but in the number of cells counted, it was more of XX, but some of the cells showed XO. So she's labeled as mosaic Turners. So now coming to, we have this double trouble now. We have to counsel this girl and the father about Turner syndrome and its own risk factors, how to follow up this child for that purpose. And also now she has ended up with a recent onset obesity. We all know that Turner's children are more prone for obesity and also more prone for hormonal issues like hypothyroidism and other risk factors because of Turner's itself. And this child also has a lifestyle problem, which is the behavioral disorder here. We understand obesity in adolescence is not a cosmetic problem, less likely an endocrine problem, likely a metabolic problem, but almost always let us understand it is a lifestyle problem. So these children should undergo, every adolescent with obesity should undergo annual screening. Not only with obesity, every adolescent visiting the clinic should have the weight and height plotted and the body mass index calculated. Waist circumference is a new addition. We have to remember as pediatricians and make it a habit to measure the waist circumference, because these measurements, when we show the adolescents, it makes them understand the issue better. Recording of BP biannually is very, very important with every adolescent. All overweight or obese adolescents should be screened for metabolic risk factors. This is very, very important. We cannot just let go of them by giving counseling about diet and exercise. When we deal with these children who are already high in the chart, we should screen them for metabolic risk factors. And for that, a simple clue will be our body mass index and waist hip ratio or waist circumference. Let us have a low threshold to investigate these children, high threshold to react, and very high threshold to refer to a surgeon. So starting a treatment with drugs or referring for bariatric surgeries are not our approach, but we should have a low threshold to investigate and counsel them better, because as we all know, most of the time it is a lifestyle problem. Coming to the causes of obesity in an adolescent, it is almost always exogenous. Normal growth and development, puberty are suggestive that it is a exogenous obesity where it is more likely to due to lifestyle. But in this present child, we also have an underlying risk factors of Turner's. Monogenic obesity, where it is usually of early onset, where they have craving for food from early childhood, and they end up eating more often, not only their food, but also the leftovers by others, and impaired control. And obesity syndromes, as pediatricians, I don't have to tell you about this, you are all aware of. Hypothalamic obesity, where we will get a clue like a neurological finding, or they have now a recent onset rapid weight gain. They have findings like hyperphagia, or a neuroimaging will give us a clue. So this is hypothalamic obesity, which we should have in mind, but more commonly seen in early childhood. Drug-induced obesity, we need to ask these children about any history of taking drugs, especially steroids or antipsychotics and anti-epileptic drugs. Endocrine problems, in these children, it is very, very important to do a head-to-foot examination and make sure that we are not missing a thyroid issue and other endocrine issues like vitamin D deficiency and so on. And also it is a good idea to see their height, because short stature with obesity, we have a clue for endocrine problems. However, in this case, we do not have a thyroid issue, but we ended up diagnosing Turner's. What are the risk of complications? Like key aspects will include differentiation of physiological and pathological causes. So what are the key findings which we should have in mind as red alert signs for a pediatrician? If we come across an obese child who has delay in growth or puberty, not attained menarche at the age expected, or not developed appropriately, we should have this as a red alert sign. Dysmorphism will make us always think towards an underlying cause which can lead to obesity. Hyperphagia will give a clue towards monogenic obesity, and conditions like Prader-Willi. Early onset obesity will give us pointers towards a more pathological cause. Visual symptoms can be seen in syndromic obesities, which we have to be aware of, like Bardet-Biedl. Neurological features will give us a clue not only about a organic cause, but also about complications related to obesity. This is a Korean et al. Chart for body waist circumference, for boys and girls. And this will be a ready reckoner for us. We can have this copy in our own clinic, and so that we can mark then and there according to the age, what is this child's waist circumference. When we measure the waist circumference, we measure it in between the lower point of the rib, lowermost point of the rib, and the uppermost part of the iliac crest, and take that measurement with a non-stretched tape. That is very important, and mark it, and also use it for follow-up, because when they come for follow-up, you show them shedding weight at the waist circumference, it motivates them better. How to approach adolescent obesity? As we discussed, these are the red flag signs. Any height less than third centile, like we saw in this child, we should be alerted. A delayed bone age, a growth velocity which is poor, less than 25th centile, a hypoplastic genitalia, menstrual irregularities like not getting the periods on time, or oligomenorrhea, which was again a clue in this child. Syndromic findings or dysmorphisms, visual impairment, severe hypertension, again gives us a clue. Focal neurological deficit. These are some of the red flag signs where we need help of a specialist like an endocrinologist to help us and deal with this child better. If these things are not there, we can label them as nutritional obesity, which can be these children should undergo screening for cardiovascular risk factors and metabolic syndromes. And if it is positive, then this we label as obesity with cardiovascular risk, or if it is negative, we label them as simple nutritional obesity and proceed with counseling. Important laboratory cutoffs, as we already saw, we need to evaluate children with obesity definitely for metabolic risk factors, which will include a basic fasting and postprandial blood sugar. We do a liver function test to look for any non-alcoholic fatty liver disease, any derangement in the liver enzymes, and measure the total cholesterol level and triglyceride to find whether they have proneness for cardiovascular risk. And this is a chart to give us and what is the acceptable level in an adolescent in the age group up to 18 years, and what is borderline and what we should definitely focus more. Now moving on to the counseling. Once this child is investigated, evaluated, and we know the underlying risk factors, now we proceed towards counseling, which includes two important prongs. One is dietary, another is the physical activity. These two are the most important areas on a day-to-day basis which they have to follow. Coming to the dietary counseling model, we know start with screening, assess this child, then start the discussion. Discussion should include both the child as well as the parents, because this eating habit has to now become a family meal, and they should also tend to follow the same so that the child is not put off. If others are eating unhealthy foods or junk and the child is made to eat a healthy food all the time, it's going to be difficult. Setting goals, again, as we saw in the last case, realistic goals have to be set. If you say categorically no to foods, these children are going to be put off, they won't come for follow-up. And monitoring is very, very vital, especially in a child with obesity with cardiovascular risk factor. What influences the food habit of a child? Like when we see this plate, we know it reminds us of the healthy food plate which is put forward by the Harvard Medical School. But we can use the same food plate to understand this child's intrapersonal, interpersonal, immediate family, the environment and the society, and then the national programs related to adolescent food habits. All these things play a role which influences. So availability of cheap and easy foods, which is packeted, which is also tasty and advertised by media, these things immediately influence the age group of adolescents, where they tend to crave for such kind of foods, as we all know that these children are emotionally driven rather than intellect driven. Just a second, I will connect to the battery. 1 second.
So post-COVID, obesity and scholastic backwardness have been on the rise because 2 years of non-schooling, and so the scholastic backwardness has been rampant actually in the schools due to distractions and disruptions. And of course, obesity is also on the rise because of COVID, and we are seeing so many cases and so many children and adolescents with COVID, post-COVID. So these two areas are really of concern, and we as pediatricians definitely have to do. Yes, yes, doctor, please proceed.
Yeah, thank you, sir. So to focus on physical activity, so we can talk to them about the kind of exercises they have to do and the time, at least for an hour or more of physical activity on a daily basis, and the kind of exercises which they enjoy. That becomes very, very important when we counsel them. If we tell a child to play instead of dancing, especially girls who enjoy dancing more, then this follow-up becomes very difficult and they tend to stop that exercise. So aerobic, muscle strengthening, bone strengthening, these are the three categories which we have to talk to them and give them small examples, or also do in your own clinic and show them, which will motivate them better, because role models are always better for this age group to counsel effectively. So the healthy lifestyle recommendations, which is evidence-based, will be physical activity of different kinds to strengthen their muscles, bones, and also aerobics, which increases their heart rate, healthy nutrition and diet. And we know the acronym JUNKS, which has been coined by our IAP Presidential Action Plan in 2021, where we need to stay clearly off junks. That junk includes HFSS, which is high in fat, sugar, and salt. U for ultra processed foods, N for nutritionally inappropriate, and C for caffeinated, carbonated, and colored, and S for sugar sweetened beverages. So these junks can be kept as a poster in our own clinic. So whenever they come and they see that, it is going to have a visual impact. Getting adequate sleep is very, very important, because we know our adolescents spend very less time in sleep. So they feel more sleepy during daytime, which can affect their daily routine. Controlling stress, for which both parents, teachers, and pediatricians have a role to counsel. Goal setting is very important when it comes to obesity management. We have to talk to them about alcohol and drug use and the drawbacks with it. And more important is the screen time. And all these 7 factors play a role in achieving our target. To just for completion, a slide on drugs. Metformin, again, we are not promoting any drugs for obesity as a first hand. It is recommended for type 2 diabetes mellitus after 8 years of age. It is also used in polycystic ovarian disease who come with insulin resistance. Orlistat is a drug which is a gastric lipase, gastrointestinal system lipase inhibitor. It decreases fat absorption, but it is only approved after 12 years of age and used in foreign countries in morbid obesity. Surgeries are strongly discouraged, but as pediatricians, our role is to continue to motivate, give a diet plan, and continue physical activity schedule. And this is what we have to take home message to deal with adolescent obesity. So give them a plan of regulating meals and not to skip breakfast. Very, very important to tell this because most of the time the obese adolescent skips breakfast and thinks that he can lose weight. 45 minutes to 1 hour of daily vigorous physical activity, avoidance of in-between snacking, and if they feel very hungry, they can always indulge in the go-to foods, which is always vegetables and fruits. We are aware of the traffic signal symbols which are used for counseling an adolescent diet. The red is no, and the yellow foods, which are mainly the grains, the whole grains, and which can be eaten in limitation. Milk products, dairy products have to be taken in moderation, whereas the green foods will be the vegetables, fruits, legumes, the whole grains, lean meat, fish, and so on. So we have to talk about that and tell them whenever they feel hungry, what kind of food they have to approach. Avoid rigorous dieting. That is very important. So you have to set realistic goal where they lose 0.75 to 1 kilo every month. This kind of weight loss is sufficient rather than over dieting and losing lot of weight. Specialist referral in the presence of complications. I lost a slide on prevention because as pediatricians, our role is more important in preventing such things happening, not only to treat once it happens. So we can use this 5210 model where there is 5 servings of fruits and vegetables have to be included in the diet. So whenever we start talking to a adolescent, even if they have come for different complaints, once we address that, it's a good idea to have 5 to 10 minutes of talk to them about healthy lifestyle, where we can tell them the importance of taking in micronutrients, that is fruits and vegetables, 5 servings, reduce the screen time to less than 2 hours a day, play for at least 1 or more hour every day, and keep away from the junk. So that is 0. So these things and usage of illustrations and dealing with will help a long way in dealing with adolescent obesity. Not only we have a role in treating these children, but also more role in prevention of childhood obesity, which is an emerging global health problem. Thank you so much, and I'm happy to take questions.
Wonderful, Dr. Jayashree. It was a wonderful session. And to sum up, actually, the solutions you have given is wonderful. And general solutions for the parents will be, parents have to update and innovate. They have to empathize with the adolescents, allow them to become individuals, be an inspiring, motivating, and positive role model. And of course, value-based education has to be inculcated in them, and using technology for the right purpose has to be there. And adolescents, the parents have to deal with the adolescents as friendly as possible and not as a friend. So the one question for Dr. Jayashree will be, for obesity, can we recommend this low carb or keto diet?
In children, I have not come across any such recommendations, sir. We have to only stick to this regular diet, but follow 1,200 or 1,500 calorie diet, which we can advise, but not definitely a keto or the ketogenic.
So the low calorie diet is advisable.
Yes, yes.
Okay.
So we are covering that in rapid fire, sir. Sorry to interrupt that.
Okay, we'll finish up the session. Thank you, Dr. Jayashree.
Thank you, sir. Thank you.
Thank you
Thank
so
you.
much, Dr. Lakshmi Shanti and the organizers. Thank you.
Thank you, Chendil sir, for taking your time in spite of your time with your family. Thank you so much. That shows your commitment to adolescent health and cause. Thank you, sir. So we'll just move on to the final session, which is a rapid fire question and answer session that has been it has been focused on some simple issues that we face in our day-to-day practice and how to go about it. So to moderate this session, I invite upon our active and dynamic President AHA Coimbatore, Dr. Usha Elango ma'am. She runs an adolescent clinic in Coimbatore. She has been as the president and secretary from Coimbatore IAP. And now she's currently the president of AHA Coimbatore. So we have been actively doing activities in Coimbatore. And I'll also like to invite upon Dr. Mohammed Ismail, who is an active AHA member and a very active and interesting speaker. He has done many activities in schools. He has taken the initiative of meeting the students in schools and done many group sessions and individual sessions. As we all know, he has been the president IAP TNSE, and he has done an active part in especially during the COVID times. So Dr. Usha ma'am, so if you can just start talking, I'll just share the screen and the presentation.
Thank you, Lakshmi.
Ismail is a central EB member for 23.
Yes, so we have two central EB members, Dr. Ismail sir and Aram Chendil sir. Both of you, I think you can take some initiative for adolescent health, sir, next year.
Thank you, Lakshmi. Thank you for your nice introduction. And good morning, all of you. Sorry for joining late. But anyhow, let us go with the session, please.
Good afternoon, everybody. And thank you so much, Lakshmi, for organizing this event so beautifully and in a short span of time. So we thought a couple of quick questions will also put focus on these important issues in adolescent health. The first one being about the cervical vaccine. So the question is, a 14-year-old comes with her mother for a minor ailment and asks you, I want to get a cervical cancer vaccine. Or we see this kind of things in a routine checkup to advise them regarding cervical cancer vaccine. Will it prevent from getting cervical cancer by 100%? So the thing is, how do you counsel these children? The IAP recommendation for vaccine is, as everybody knows, is 2 doses with 6 months apart from the age group of 9 to 14 years of age, and 3 doses if it is beyond 15 years of age. If there is any skip up of these vaccines in between, a minimum gap of 5 months is always advised. And also a gap of about 12 weeks interval is also sufficient. In case the dose is delayed, there can be a restart of there need not be a restart, but the vaccine can be just taken. Now, who can take the vaccine? Any adolescent beyond from the age group of 9 years of age can take the vaccine. And the earlier, the better, because nowadays we are seeing even in adolescents being sexually active. So it is advised much to take it as early as possible. It is estimated that right now, according to the statistics, 1 woman in India dies of cervical vaccine for every 8 minutes. So this implementation of cervical cancer vaccine through the pediatricians is very mandatory. Only a couple of companies have the vaccine availability right now. The government is yet to implement this vaccine in the routine vaccination schedule. So, so before the HIV infection happens, advice to take the cervical cancer vaccine is most important. The efficacy, yes?
Yes, ma'am, please continue.
Yeah, the efficacy of the vaccine is found to be nearly 100% and in preventing both cervical, vulvar and other vaginal infections. It also prevents from all the 7 causing HPV types. The now available one is the quadrivalent vaccine, which protects against the 6, 11, 16 and 18 types. Nowadays, it's recommended for adolescent boys too, so that they do not give this infection to the girls. So it is very much recommended right now for adolescent boys too. So I think during our practice in routine practice, even we should implement and we should proudly counsel the children coming for routine checkups or routine vaccination or for any other illnesses to take this positive initiative towards cervical health, cervical cancer vaccine. But it's also important to give guidance on safe sexual practices to the adolescent group. Any questions on that?
Just to add a few points, ma'am. So actually, we also have the non-covalent vaccine available that prevents against the 9 serotypes of HPV. And regarding the schedule, the first 2-dose schedule is 9 to 14 years. And there should be a minimum interval of 5 months in between the first and second dose. And coming to the 3-dose schedule, the first and second dose should have a minimum of 4 weeks.
14 weeks.
Yeah, and 12 weeks.
Gap.
And pediatrician have to remember that if the interval between the first and the second and the third dose is less than 5 months, then we need to repeat a dose. So that is one thing that has been given by the manufacturer. But when a dose is delayed, there is no need to restart the schedule. We can just complete. And now we have a latest study from the WHO, which says that, which is a 10-year study, says that even a single dose of the vaccine gives excellent vaccine protection. So far we have the only restraint in giving this vaccine is the cost. So at least 1 dose of that vaccine can be given to whoever can afford it. And of late, recently, we're also going to get the Serum Institute vaccine, which is going to come at a low cost. Maybe that will improve the vaccination rates. And for this girl, like, we would also give that anticipatory guidance of safe sexual practices, because they think that giving this vaccine prevents them from all form of diseases. It's not like that. And with increasing prevalence of HPV that is being attributed to oral, oropharyngeal, vulval, and anal cancers, not only in girls, but also in boys, there are many reports of increasing evidence of cancer. So this has been given to adolescent boys according to the CDC. But as of now, we don't have that IAP recommendations for giving it to adolescent boys. So
I think there is only one vaccination. One vaccine is available now. Gardasil alone.
Yes,
Cervarix is not available, I think.
Cervarix is not available. We have only Gardasil, and Gardasil 9 is very costly. So that is the only restraint. But I think many NGOs are being, they've been taking this initiative to give these vaccines free of cost. So as of now, when we meet adolescents, we can counsel them and we can give the doses early. So 9 to 14 years means 2 doses is enough. So coming to the next question, 14-year-old Mr. R, who has come for a recurrent headache, on history taking reveals that he has started gymming of late and taking energy drinks influenced by a close friend. So this question I would like to ask Dr. Ismail, sir. What do you advise?
Yeah, good morning, all of you. I think this is an interesting question, actually. I've got a personal experience of one of my friend's son, actually. He has gone to the gym and he started consuming all the energy drinks. Not only that, he wants to build up his body to becoming more masculine. I think he had taken a lot of protein drinks and as well a lot of the whey protein, which has been recommended by the gym persons. And finally, he ended up in a lot of trouble. Actually, he lost his hair. He had a lot of sleep disturbances. He had psychiatric disturbances. So many things are activity. See, before going into the energy drink per se, I think we as a pediatricians, we should all aware what IAP guidelines have been, what has been recommended for an adolescent kid, what sort of a physical activity. Actually, we should know there should be at least an hour of physical activity daily and more of an aerobic activity. He should shed the sweat, and not only that, he should have some cardio workup, and it should be more of a physical aerobic activity, and it should be a dynamic event. And not only that, today's youngsters are more being misguided by the person who owns the gym or the friends which do a lack of knowledge. They just go through the YouTube and they just wanted to show masculine structure, like the actors like Shah Rukh Khan or something like that. They do so many muscle building exercises, but ultimately what recommended is a physical activity, strengthening exercise, both for the bones and muscles. That's all they require. So a parent should be advised to focus on the kids, to look into their exercise, their activity. Unnecessarily, they should not go for powerlifting or lifting, weightlifting, and something damage their tendons and budding all the muscles in the adolescent period, which is going to be priming. The tendons will be growing now. I think if they do a lot of activities which will damage their tendons and tissues, I think that's going to be a problem. And coming to the part of the energy drinks, the history dated back in 1900 itself when Coca-Cola was introduced. Coke, and actually it has been the name itself is derived because Coca-Cola contained cocoa leaves and actually cola seeds. That is the caffeine. Caffeine was the basic thing. Ideal recommendation of a caffeine in an individual should not exceed 400 grams per day. That is the recommendation. 400 milligram, I think, if I'm right. The thing is, but all the energy drinks which is available in the market, especially the popular one is the Red Bull and this Monster, and of course Herbalife and other things. All this contains, if you go into the ingredients, they have a lot of herbal extracts like ginseng, and of course caffeine is there, and of course maltodextrin and glucuronolactone, so many other compounds they have with the chemicals which have been constituted to promote focus and concentrate on the event. So caffeine is a stimulant, and as well it is a diuretic as well. And all the herbal extracts which have been used, they will also act as a diuretic. So the children will become more of dehydration. They go for a tissue level dehydration and then get injured themselves. So I think as a pediatrician, you should advise the parents as far as the thing, they should have a thorough knowledge about the energy drinks. What are all the side effects caused by the energy drinks is, in the cardiovascular side effects, it can shoot up the BP. Sometimes it may show varied heart rates, precipitate the arrhythmias. Of course, as he rightly, this guy who had come, this 14-year-old guy come with the headache, it's a possibility because of an energy drink. Because of it is the cortex getting hyper-excitable state because of the caffeine overdosage. And of course, they have a behavioral disturbances like sleep disorders, and they have anxiety. Of course, rather contrary to lose weight, because of the more consumption of energy drink, especially along with alcohol, they might go in for an obesity, and of course they can precipitate type 2 diabetes mellitus. And of course, as I said, renal complications is also there. And of course, you can lose your dental enamel also. So I think we as pediatricians should advise the parents regarding what is required in the gym and how to go about the gym activity per day. What is recommendation? As far as the energy drink is concerned, it is a homemade black coffee will be enough, or a lime juice will be enough. No energy drinks. That is the message given. Thank you.
Thank you, sir. So in addition to the energy drinks, we also have this problem of protein shakes that are being recommended by the gym trainers. Usually adolescents don't listen to us, they listen to the gym trainers, and they take all the protein shakes also. So as parents and pediatricians, we need to see the constituent list of these shakes and give them an idea of what they contain. Suppose if there are sports people who want to train in a particular sport under a proper training, maybe they can do it.
True. You're absolutely true.
Thank you, sir.
Thank you, Lakshmi. Thanks for wonderful organizing. Thank you.
Thank you for joining, sir, in spite of your function. So coming to the next query, 15-year-old Mr. S brought by his mother with complaints of a withdrawn behavior of late. On HEADS assessment tells you he's being body shamed in school because of his gynecomastia and wants surgery to get rid of it. So what's your advice? So Usha ma'am, I'll just go about this.
Yeah, please go ahead.
Coming to this is a very simple and not so common, but we do come across adolescents with this problem. And believe me, this causes a lot of psychosocial distress to the adolescent. Only if we can empathize and put us in their shoes, can we understand this magnitude of this problem, because we think it is a very simple problem, nothing to do, we can just wait. But for the adolescent, a boy especially, this creates a lot of psychosocial distress. So coming to gynecomastia, prevalence is 4% in males aged 10 to 19 years. The pubertal one is more common, which is physiological, and it commonly seen during the Tanner stage 3 to 4. It's mostly due to an imbalance in the androgen and estrogen ratio. It's self-limited in 75 to 90% and regresses over 1 to 3 years. The pathological gynecomastia is very rare and is related to estrogen excess. This excess can be an exogenous source or it could be an endogenous source, like from we have tumors, testicular tumors, etc. Or it can be due to an androgen deficiency or androgen insensitivity. And another cause is the increased peripheral conversion of androgen to estrogen due to the increased aromatase activity. This is an important point to note because we see mainly obese adolescent boys with gynecomastia. So this peripheral conversion of androgen to estrogen is more in the obese because fat is a big source of conversion of androgen to estrogen. So this is, again, we can highlight this and ask them to lose weight. And while curing the obesity, it also cures the gynecomastia, which regresses on its own. So this is what I was talking about, the pseudo-gynecomastia, which is seen in the obese adolescent boys. So the most of the fat which causes the swelling and not the glandular tissue. It's also seen in some boys who do more weight training, as we saw in the previous thing. So this muscle hypertrophy can also cause a fullness in that chest area. So we have something called the nipple areolar complex, which is a small area in the adolescent boy, which is it's mostly around 28 millimeters, which means 2 to 3 centimeters is the normal nipple areolar complex in an adolescent boy. So we have the grading of gynecomastia. We needn't worry about this because we usually refer them to a plastic surgeon. So we have grade 1, 2, 3. We have 2 types of gradings depending on the enlargement with or without skin excess. And one thing we have noted too is the ptosis, which almost resembles a female breast. So that is what causes them a lot of psychosocial distress. And we need to address this. So like how Dr. Shripriya said about the body image issues. So this causes a lot of body image problems and we need to counsel them, and it's a temporary thing and it will regress on its own, and ask them to be more positive in dealing with the bullying. But there are indications. For example, in our 15-year-old boy, it was present for almost more than 2 years, and he had an amount of glandular tissue which warranted surgery, and finally he went for a surgery and he's doing well now. So the indications for surgery would be a persistent enlargement after a period of observation of 12 months, or if they have any intractable pain or tenderness and significant psychosocial distress. Okay, so now coming to the next question. A 15-year-old high school girl brought by a mother with missed periods and pain abdomen is found to be pregnant. The mother is in denial mode. How do you counsel? Usha, ma'am. Usha, ma'am. I think she's, ma'am. Okay, so coming to this girl, she's in the middle adolescence, and talking about sex and sex education is still a taboo in our country and most of the cultures, but we need to talk the talk before they walk the walk. And this middle adolescence, what happens in their bodies and sexuality related issues is very important. We need to educate them and give them anticipatory guidance. So what's going on in this age? They have continued physical growth, bodily changes. Because of this, they have an increased interest in being seen as physically and sexually attractive, and adjusting to a sexually maturing body and feelings gives them this emerging sex drive. And in this, media plays a major role. So exposure to media increases the sex drive, and they tend to engage in dating and relationships with all giving into their desires. And there is a continued development of personal identity and independence, and they want the parents to be less involved and they're more influenced by the peer groups. So because of all these normal changes that takes place in middle adolescence, this is one problem that we are facing. It's not a very common issue, but still we see adolescent girls coming with missed periods and finally turning out to be pregnant. So as we all we had discussed since the beginning of the CME, the role of media, not only how much parenting challenges it can cause, but also it causes a lot of issues in the adolescent sexuality. So they exposed more to porn and other sexually explicit images, and all the series and all the OTT platforms talk about sex, homosexual issues. So they are more exposed to media, and the information they get. The sexual content in the media plays an important role because they don't get a first-hand information from a reliable source. And various studies have shown a direct relationship between the media exposure and early sexual activity, but not all is bad. There is a ray of hope. Simple exposure to sexual content alone doesn't make teens deny or ignore values. So this is where parenting and community, we as pediatricians can have some role in educating these adolescents and giving them anticipatory guidance to prevent such early sexual activity. So communication is key. So we have talked from the morning about communication and how to communicate to a teen, be authentic, active listening, refrain from judgment, which is very important in this girl, because the first reaction of the parent would be to be offended and get angry with the adolescent. But it's very important to have a non-judgmental attitude and help them find the right resources. So parenting tips, a non-judgmental attitude is the key for communication. Don't punish your teen. If you find them watching porn or masturbating, create healthy diversions. Teach them media adequate. We are seeing a lot of problems with social media, and teach them safe online behavior. Media literacy is what we need to teach them. Keep a watch on them, but at the same time, don't hover around and indulge in helicopter parenting. Respect their feelings when they disclose their friendships. For example, if your son or daughter comes to you and says, I have a crush on this boy or something, don't immediately get angry and express, but just take this a point. As we saw Dr. Shripriya telling about that emotional coaching, take this opportunity to communicate with them and respect their feelings. Teach them about the benefits of late gratification, and last but not the least, be a role model parent. So coming to the last query. So a 16-year-old obese adolescent girl comes to you for advice regarding keto diet for weight reduction. So as we saw about adolescent obesity, excellently handled by Dr. Jayashri, the various causes and various issues related to obesity. This is one other issue that we face in our clinic with adolescent girls, and especially when they are in the late adolescent, 17, 18, they want to lose weight in a they need to use a shortcut method. They don't want to strain or do exercise. They want to do it very fast. And added to this, we have a lot of advertisements like saying like using the shortcut route to lose weight. But these can be very risky for these adolescents. So Chendal sir was also talking about this keto diet and all those things. So we have something called the fad diet. A fad diet is a trendy dietary pattern known to be a quick fix for long-term problems. So there is some missing food group in all of these fad diets. For example, it could be a low protein, it could be a low carb, or it could be a high fat. So there are a combination of diets, like we have the Mediterranean diet, we have the paleo diet. So there is a missing food group in all of these fad diets. Because of this, it becomes nutritionally inadequate, and it promotes short-term changes. It will cause a weight loss. It will cause a weight loss, but there is an issue of maintaining this weight loss. And it is detrimental for those with chronic diseases and some other issues. And there are inconsistent evidence regarding these fad diets. But this rapid weight loss that comes with this fad diets makes these adolescents more attracted towards this. So I'm actually telling all these details only regarding the adolescents, and I'm not against a paleo or keto diet for the adults or this. So that topic is beyond the scope of this CME. So this fat diet prevention is only for the adolescents. So this leads to something called a vicious cycle. They go on and they start this diet and they restrict certain food group, and finally they feel deprived and tempted, which leads to cravings. Finally, they give in to their cravings, and then which leads to guilt, low self-esteem, and poor confidence. So we need to teach this to this adolescents who come with this idea of following these fad diets, and we need to educate them that this is a short-term thing and it shouldn't be followed, and especially because they are growing to a lot of physical and development. So a proper balanced diet is very important in the adolescent age group. So as we all know, as pediatricians, a balanced diet is achieved when the energy intake is equal to the energy expenditure. It means 45 to 65% of calories from carbs, 35 from fats, and 10 to 35 from protein. And we also make them understand about the junks, as Dr. Jayashree said, the total fat shouldn't exceed 30 and saturated fat should be kept less. Free sugars, which is readily available in the energy drinks, fruit juices. So all these should be restricted. And again, salt intake should also be kept minimum. So we talked about this healthy eating plate already. So we need to advise them on having a balanced diet and follow the healthy eating plate and avoid junks. So this is, and also physical activity, as we saw the guidelines, physical activity guidelines, and proper sleep. So all these changes will bring about a positive change in weight loss and also good development in their behavioral issues also. So for adolescents, fad diets are not advisable. So thank you. I think this is about the question and answer. Thank you, Dr. Usha ma'am and Ismail sir for joining this session. So we have come to the end of the session.
Thank you, Dr. Lakshmi Shanti, for arranging. Thank you, Dr. Lakshmi Shanti and Dr. Usha Ilango, madam, for arranging this session in a short span of time. Wonderful session. Thank you. Thank you so much.
Usha ma'am, I think she raised her hand. Usha ma'am, are you there?
Many people are raising hands.
Yeah, I don't know, like if they put it in the chat box, I think we can just fastly finish if there are any questions. Otherwise, I think we'll end the program because it's already time. Usha ma'am? Jalil sir, are you there? Would you like to add a few points, sir?
No questions in the chat box, no?
Yes, sir. So I think
Can the participants speak?
Dr. Agnes Selvi has raised hand. Would you want her to?
Dr. Thiru is there?
panelists only can. There is one question I'll see, sir. Oh, chat box is disabled. So I don't know how to. Tirumurugan, sir? I think they're not.
Agnes Selvi, she can speak.
Yeah. Good evening. Good afternoon, everybody.
Good afternoon. Good afternoon.
Yes.
Yeah, this is Agnes who was continuously raising her hand because the chat box was disabled for us to introduce or to appreciate also. That is why I was continuously raising. And I really, really thank this team of doctors, the pediatricians, the adolescent counselors for enabling all the academicians also to attend. Thank you very much. Because this is the need of the heart. We are finding it very difficult to handle the children post-COVID. It is, we don't know with what mood children are coming and sitting, and they while the teachers are teaching, while we are talking to the students, they look vague and they are not responsive. But you people have given a very good platform, and I really want to congratulate from the other participant side that a very good initiative taken by the whatever the abbreviations you people were telling. And you also quoted that one of the doctor quoted that in 2023 schools are going to be collaborated with from the
Yes.
Tamil Nadu government, and it is
Yes.
very, 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 very good initiative. And being the doctors and pediatricians, so your Sunday is very, 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 very essential for your family, and especially December time is like what is a vacation time for you. And I thank from the bottom of my heart on behalf of all the other participants that for your taking your valuable time, quality time spending with the teaching fraternities to what is it, giving assurance that you will be very soon joining us and bringing up the good citizens of the future. Very good. That's
Thank
why I wanted to connect with.
Thank you so
Thank
much,
very
Mrs. Agnes. We are so happy that you have been representing the teaching fraternity. So I think that is the success of this program. Like we do this for the adolescents. So adolescents are more connected with the teachers. So I think when you have connected and you have taken some information, and if you can spread it across, then that will be the success of this program. Thank you.
I thank the teachers, TN educators group for enabling us, for getting us this information. Dr. Sumati ma'am. Sumati ma'am only posted this, and immediately I think many of us have joined. Very, 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 very good. And we missed the slides of body image or the body shaming slides was shared, and that was not at all visible.
Okay, okay. So I'll
Slides were
try
too good.
yeah.
Slides were too good.
Okay, so I'll try to share it, ma'am, with in your group.
Yeah, thank you.
Thank you so much for attending. Thank you. If there are no other questions, I think we can finish.
We can wind up.
Yeah.
Hello.
Yes.
Yeah, I'm Dr. Madhushri from Chhattisgarh, and I'm listening to your program. It was such a nice program. Very, I want to congratulate all you. Such a nice program your people have done. Thank you very much. Thank you.
Thank you so much, ma'am. It's a honor.
I am a former AHA chairperson from Chhattisgarh IIP, and it was worth listening, and it was so interesting. I am tuned from 11 o'clock till now.
Thank you so much.
A big thank you to all of you, all the parties, all the other what should I say, all the panelists and everyone. Very nicely conducted.
Thank you so much, ma'am.
Thank you.
I cannot stop complimenting you people, because when it is from government side, people have a wrong assumption that they won't do good that much. But the competency has improved, and the attitude, and what not I can say. There are genuine people. It is okay. Time is changing. Revolution. Very good. Very good.
Thank you so much, ma'am. I think we have come to the end of this interesting end of the year CME and adolescent issues. So I would take this opportunity to thank all the panelists, our AHA Coimbatore President, Dr. Usha Elango ma'am, our State Secretary, Dr. Rajendran sir, who joined in for the inauguration, Dr. Chendil Aram sir, Dr. Ismail sir, both Central EB members from Tamil Nadu and active members of AHA, my co-panelists, Dr. Jayashri, Dr. Shri Priya, Dr. Vijayarani ma'am, and all the delegates who attended on this Sunday, made this program a very successful one. I thank you all. Thank you all, and thank you, Dr. Tirumurugan, for giving us this DAAP
platform.
Yes.
Lakshmi Shanti மெனக்கடல் தான் இவ்வளவு நல்லா இருக்கு. Thank you.
Thank you. So we wanted to make a physical one, but I think this has connected more people from across. Maybe we can plan a future one in physical.
Yeah. 23 we'll make it large.